What a wonderful way to begin the day with music from Tomiko French, owner of Soul Speak Expressions, who is leading the healing breakout session. So please don't all run into healing now. Over the last 18 months, we've been working on a community health needs assessment alongside many of you that help shape our community health priorities, racial disparities in health, and life-impacting traumas. Our data and community conversations revealed the impact of various traumas in people's lives, whether adverse childhood experiences, adverse community events such as community violence, or the trauma of facing systemic racism in the COVID-19 pandemic. As we named life-impacting traumas, we talked about the power of being in community, working together to address common needs and issues. And today's symposium was born from those conversations. We heard over and over again the importance of North Memorial Health becoming a trauma-informed system so that we shape policies and practices designed to reduce the re-traumatization of patients, families, friends, community members, and the professionals who serve and support them. We recognize the U.S. healthcare delivery system has historically caused trauma through systemic segregation and discrimination of patients using harmful experiments and research that reduce their dignity and cause lasting consequences. Through the use of a trauma-informed approach, which is a profound paradigm shift in knowledge, perspective, attitudes, and skills that continue to deepen and unfold over time, we at North Memorial Health are actively working to dismantle racist and discriminatory practices and policies in our healthcare system and communities through the development of services that lead to equitable outcomes in health, authentic engagement within our community, inclusiveness, and respect for one another. We believe that today's symposium will provide all of us meaningful information, new tools for us to use in our jobs and work with community members, and self-care activities that each of us can do to maintain our own health as we work with traumatized patients, families, colleagues, and community members. Our journey today begins with learning about the types of trauma and the principles of trauma-informed care. We'll hear from community members who have experienced trauma, how that trauma both impacted and influenced their lives as they nurtured their response and resilience, healing, and hope. Throughout the day, we'll learn strategies for healing, radical self-care, and burnout prevention. We've assembled some incredible presenters and speakers, but equally with all of you here to advance the important conversations and work we'll talk about today. So thank you for being here. I'd like to share some logistics about the day. Conversations about trauma and hearing about traumatic experiences can trigger varying feelings and emotions. First and foremost, we want you to make sure that you prioritize your well-being. At any time, feel free to step out of the room and get some fresh air outside and/or visit the Reset Lounge. Carrie Appleton, North Memorial Health's resiliency coach, has set up a Reset Lounge across the hall, which is a space to pause, settle yourself if you're feeling impacted by stress. The elements in the space can be used to assist with resettling or grounding yourself to the present moment. We ask that you enter and exit quietly. There is a journal in your folder for note-taking, self-reflection, and self-care. We hope that you find it meaningful throughout the day and after you leave. Please know that we welcome everyone's lived experiences and authentic self. We are here to learn and not judge anyone's experiences. We accept that there are multiple truths and perspective of everyone's life story. All participants are welcome to use restroom facilities that correspond to their gender identity and/or expression. There are 2 all-gender single-stall restrooms located outside this main room, and then several multi-stall bathrooms located in the back of this room and in Grand Room 1. We will email information out about how to access PowerPoint presentations following the symposium. At the conclusion of the symposium, for those who want it, CME certificates will be available for pickup at the registration table. If you need assistance at any time, please ask the individuals with the blue name tag, like mine. We are honored to have Jordan Hamilton and Bayou Bay, located in the back of the room, join us today. These 2 artists are creating artwork reflective of today's symposium that will be displayed at North Memorial Health's 2 hospitals. Finally, today's symposium would not have been possible without the support of North Memorial Health's Foundation and the City of Brooklyn Parks Recreation and Parks Department. We would also like to thank our co-sponsor, Northwest Family Support Coalition. At this time, I would like to invite Bjorn Gunnerud, North Memorial Health's Chief Strategy Officer, to the stage. Bjorn joined North Memorial Health as Chief Experience and Marketing Officer in 2021 and became our first Chief Strategy Officer in 2023. Bjorn approaches everything he does with curiosity and a commitment to understand what matters most to the end users of a particular project or problem we're trying to solve. His belief that for any organization to be successful, they must continually create real, relevant value for the customers they serve. Bjorn has left his mark on a diverse mix of brands, including CVS Health, MinuteClinic, Children's Minnesota, Henry Ford Health System, Citibank, and BMW of North America. He's active in our community, including the YMC of the North Board today. Please join me in welcoming Bjorn.
Does that work? Can you all hear me? Thank you, Jesse. And good morning. And thank you all for creating space in your busy lives for our discussion today. Seeing the guest list for this morning, it was so great to see such a diverse mix of people, perspectives, roles, and organizations that you all represent. So hopefully you're sitting with some folks you know, but also take a chance, take this opportunity to get to know some folks that you don't, because I think there's really some amazing people in this room, and certainly some important opinions that hopefully throughout the course of the day you'll get to appreciate. So when Jesse first presented the idea that we, North Memorial Health, needed to become more trauma aware, I chuckled a bit. As a level 1 trauma center, celebrating 25 years of accreditation this year, and having served well over 50,000 patients with a 97% survival rate, I thought, Jesse, I'm fairly certain we're not only aware of trauma, but we're doing a pretty amazing job at not only at our Robbinsdale Hospital, but at our Maple Grove Hospital too. Though I have the privilege of welcoming you alongside my colleague, Jesse Kingston, I'm most eager to sit back down and learn alongside you based on the tremendous panel of thought leaders and experts that we've assembled to educate, provoke, and inspire our shared work in addressing life-impacting trauma in our communities and at North Memorial Health. We believe becoming a trauma-informed system will raise the level of interaction with patients, their families, and community members as we incorporate their lived experiences into healthcare and healing. And the experiences for so many are real. The effects of the pandemic and systemic racism have resulted in large numbers of our population feeling depressed, anxious, and isolated. In addition, traumas such as deaths from COVID-19, community violence, opioid overdose, and suicides have left many people grieving and in need of support to help them heal. Our health needs assessment found that many youth and adults feel a lack of social support. Additionally, the Minnesota Student Survey data from our region showed too many youth had 3+ adverse health or adverse childhood experiences, or ACEs, by 9th grade, and or had self-injured themselves in the past year. As the father of 2 9th graders, this is incredibly shocking, and something that is hard to imagine. North Memorial Health's mission is to empower our patients to achieve their best health. And our vision is together, healthcare the way it ought to be. So how ought it be? Well, let's agree that we can do better in addressing the impact of ACEs and toxic stress in our community starting today. Ideally, before people ever need a trauma center like ours, and if they do, with full confidence that our teams are not only prepared to deliver exceptional care, but also for the unseen and the unsaid. We stand committed to pushing the ease of access to the resources, knowledge, and tools that people need to achieve their best health, and recognize that providing trauma-informed care to every patient and family, we will build stronger levels of trust, provide a better experience, and improve health outcomes. Care that looks beyond symptoms alone to understand the whole person of each individual and all the experiences, strengths, and resiliencies. What a great and challenging day we have in store. So thank you again for being a part of this journey. And thank you. Enjoy the day. So thank you.
Thank you, Bjorn. I'm excited to introduce Dr. Ryan Van Wyk, our morning keynote speaker, who will help lay the foundation for understanding trauma and trauma-informed care. Dr. Van Wyk is the specialty lead for Mental Health Services Center at North Memorial Health Clinic in Robbinsdale. As a licensed clinical psychologist, he specializes in supporting clients whose lives have been disrupted by trauma and who, in an effort to cope with the impact of trauma, struggle with persistent disassociation, substance use, self-injurious behavior, and eating disorder symptoms. Dr. Van Wyk is a behavioral health officer in the Minnesota Army National Guard with nearly 20 years of service. He is the founder of the nonprofit Minnesota Trauma Project, which was formed in 2015 to increase awareness of trauma through professional training. Please join me in welcoming Dr. Van Wyk.
Well, it's a real honor to be with all of you this morning, and a real exciting transition for North Memorial to be making towards becoming a more trauma-informed care system, and to be part of that system while it's happening. So we're going to spend a little bit of time talking about some different topics, and I think it's always important when we begin talking about trauma, just to acknowledge that you all have nervous systems, myself included. I'm feeling the presence of my nervous system right now as I step in front of all of you. But if at any point, as Jesse acknowledged, you find that your nervous system is being triggered or reacting in some way to the topics being discussed or to something that might be evoked in your own history, please take care of yourselves. And if that means stepping out of the room, that's certainly welcome. And yeah, the importance is just to make sure that you're doing what you need to do for you. So the only disclosure I have is that I work for North Memorial. So I have no other financial disclosures or conflicts of interest. I also think it's important to start with two acknowledgments. One being that this presentation is being offered on the lands that is historically and currently inhabited by the Dakota and Ojibwe peoples. recognizing the trauma of displacement and colonization. And additionally, while we won't be spending a lot of time, although we'll acknowledge it, while we won't be spending a lot of time talking about historical trauma, we'll reference it because it's certainly important when we begin talking about adverse childhood experiences, adverse community experiences. But there's much more to be said about historical trauma, intergenerational trauma. So even though that's not going to be the primary thread of the conversation this morning, I do want to recognize the legacy of trauma that is carried by non-white bodies resulting from oppressive systems created by white-bodied people. So we'll have three points of focus in our time today. I always recognize I have a tendency to want to fill the presentation with lots of information, and I have a little bit of overambitiousness, so I'm confident we'll get through it all. But we're going to spend our starting point talking about resilience, looking specifically at the nervous system and how the nervous system is shaped by our early experiences to create a greater or lesser capacity for resilience. Then we'll talk about the way in which our understanding of trauma has evolved, particularly over the last century, and the sort of implications that are now arising from an evolved and expanded understanding of trauma and adversity. And then we'll end our time talking about trauma-informed care and some central tenets of that. I know many of you, or some percentage of you, will be attending the knowledge breakout session later this morning, which will also talk further about trauma-informed care in an applied manner. So we won't certainly do justice to trauma-informed care as an approach and a way of evolving systems to better serve people, because there's much more that can be said about that than we can cover in 45 minutes. But hopefully we'll provide some basis to understand what we're talking about when we talk about becoming trauma-informed. So this quote from John Briere, I think was actually from the 1990s. He said, if child abuse and neglect were to disappear today, the DSM, which is the Diagnostic and Statistical Manual, sort of the guidebook for diagnosing in the mental health sphere, would shrink to the size of a pamphlet in 2 generations and prisons would empty. There may be ways in which that's a bit of an overstatement because it doesn't acknowledge that it's more nuanced than just that, than just child abuse and neglect. But I think the research that's gone on since he said that, beginning in the late 90s with the Adverse Childhood Experiences Study, and as we continue to better understand the impact of racism, oppressive systems, the expanded ACEs that begin to acknowledge those sorts of environments and experiences that people go through, it's pretty clear that the landscape of both the prison and the mental health system would shift dramatically if we were able to eliminate adversity and the systems that perpetuate childhood adversity. So when we begin thinking about resilience, I always think it's important to talk about the nervous system. And Stephen Porges, who's a psychologist who's developed a lens for understanding the nervous system, talks about 2 neurobiologically wired innate impulses that humans have. The drive to survive, so safety being a primary motivator and driver of human behavior, and then the longing to connect. And we'll talk in the next slide about some of the ways in which our nervous systems have become wired across time to really serve both of those functions. Well, he coined the term called neuroception, and neuroception is this capacity that is online from our very first moments in the world, where our system is constantly scanning our environment for safety or threats to safety. And that can be both threats that are inside the body, outside in the environment, or between us and other nervous systems or other people. It's below the level of the thinking brain, so it's happening without us having to actively process it. So our brain is scanning for safety, whether or not we're consciously aware of it. And then it pops into our awareness oftentimes when our system reacts and tells us something doesn't feel right here, or shifts us into one of these nervous system states that's designed to react to threat. We also have this drive to look to connect with others. And there's this important capacity that humans have and other mammals have to co-regulates, that our nervous system can shift in response to the nervous systems of others. You see this most specifically in child caregiving early on. The nervous systems are soothed and regulated by the presence and the soothing efforts of another being. Many people probably also recognize that your pets have a co-regulating impact. If you are feeling stressed, particularly if you have a pet that's a mammal, they're more likely to sort of move towards you and become a source of comfort or nervous system soothing. So this sort of movement to look to others for connection and co-regulation is a very normal mammalian impulse. And as we'll talk on the next slide, one of our branches of the nervous system is really wired for connection and social engagement, and helps us to sort of be at our best when we're able to sort of be in a specific nervous system state. So Stephen Porges talks about 3 different branches of the nervous system that developed across the evolution of human experience. And in our current iteration, we have all 3 of them. And I'll put all 3 up at once. So at our most primitive level, we have a branch of the nervous system that's, he coined the term the dorsal branch, the dorsal vagal branch of the nervous system. So this is a system that comes online when we experience severe threats, oftentimes threat to our lives. And it's a system of immobilization and disconnection. And it's both disconnection relationally, but also disconnection within. And you'll see this if you think about the animals that go into a freeze response, like a possum. This is a system that's coming online in those moments. There is a source of threat in their environment, and their adaptive response to that is to get small, try to disappear, and make themselves less visible. And in the process, this nervous system sort of decreases the energy in our bodies, and tries to conserve and preserve the resources that we have, so that if we survive it, then we can sort of move on from it. Built on top of that is a mobilized nervous system state. This is the state that we oftentimes think about in response to stress, a response of fight or flight. So if we think about the first one as sort of a collapse, shutdown, this one is more of that fight, flight, so it's mobilized, it moves us. So there's something about, I either need to move towards a threat to try to make it less, or I need to move away from the threat to try to get away from it. So the adaptation here is that our actions or our activity moves us to safety, or reestablishes safety. And so there's aggression, right? So that fight response, or more of an active escape, in which we're actually trying to flee the thing that is a source of threat for us. And then on the top of that, so as he talks about, this has sort of evolved across time. We have a branch of the nervous system that he termed the ventral vagal nervous system, which is a system of safety and connection. So he described it as a social engagement system. And this is a state that when we are able to access it, we're able to connect with others. We're able to reflect within, so our brains are more available to us when we are in this branch of the nervous system. Our digestive systems are working. So he described it as sort of a state of resting and digesting. So we're able to be in this sort of stillness without fear state, so we can be relaxed. And this is the state that our body systems are working at their best. So the immune system is working, the digestive system is working, our cardiovascular system is working at its best. And this is also a space in which we can sort of be more sort of meditatively present to ourselves, or mindfully present to ourselves, as well as be more empathically connected to others. And so as we move throughout our days, we're oftentimes having fluctuations where we might be experiencing one of these systems sort of becoming primary, and then hopefully we're finding ways to sort of move back to more of this ventral vagal state where we can come back to a place of relaxation, connection with others, connection with ourselves. We can be present in a different way. And so when the world feels like it's too much, when it's stressful, when it's activating in some way, we move into a sympathetic response. And so we move to respond to the thing that's in front of us. And that could be minor stressors, but particularly if it's threats to our safety, or to our physical well-being. If our initial activity to try to reestablish safety isn't successful, then our physiology will sort of shift back to this shutdown state to conserve our energy, to try to get through the experience and survive it. And frequently we become sort of shut down, dissociated, less connected to ourselves and less connected to others, and not as able to access resources. And these three branches we'll continue to talk about as we go through the rest of the presentation. But thinking about, even in this moment, sort of the signs or indicators of what nervous system state you might be in. There might be topics that evoke and push you into more of an activated state. You notice the energy begin to kick up. Or there might be topics that push you into more of that shutdown state where you find yourself feeling less present or sort of less engaged, and then hopefully able to come back to sort of connecting with yourself and maybe other people over the course of the time that we're here. So thinking about those nervous system states, then we can recognize that resilience begins in our developmental environments. The caregiving environment significantly impacts our ability to successfully navigate through the rest of our lives. There's a body of research, some of which was done at the University of Minnesota, that looks at attachment styles that form in the caregiving relationship. And there's research that shows that insecure patterns of attachment are a significant predictor of psychopathology and later struggles in a variety of ways. Whereas secure attachment appears to be, across the research, a form of making us more robust and resilient across our lifetimes. And so when we think about sort of our regulatory trajectory, our ability to regulate ourselves or receive sort of the regulating benefits of being in connection with others, it really starts in our caregiving relationships. So the ways in which our caregivers respond to us and respond to our needs and our cries of distress begins to shape our ability to do that for ourselves. So if we're successfully soothed a majority of the time, not perfectly, not all of the time, there's a solid percentage that shows that parents only have to get it right 30% of the time, and then when they get it wrong, they have to sort of find ways to acknowledge and sort of try to get it right again. And so security doesn't require perfection in parenting or caregiving. And so we get regulated by others first. We're soothed by others, and that develops our capacity to regulate ourselves and self-soothe. And so if we're not able to do that, either because of the inconsistent availability of our parents or caregivers, or because they're struggling in a variety of ways themselves, as we'll sort of talk more about with the adverse childhood experiences research, then we're going to struggle significantly to be able to regulate ourselves, oftentimes throughout the lifespan. And there's certainly research that shows that we are then more susceptible to substance use, to eating disorders, to self-injury. And so we struggle in a variety of ways if our caregiving environment doesn't prepare our nervous systems to successfully navigate stressful environments. So thinking then about sort of what resilience begins to look like across time, knowing that we have our own internal resources, the capacity to self-soothe, the ability to slow down when we're feeling hyperactivated, to bring energy into our system when we need it, that we can access external resources. There's solid research that shows that the presence of an attuning caregiver or another individual in sort of the social sphere of a child is a significant buffer to them being able to come out of childhood, even if there's a presence of trauma, less impacted by those traumas and more resilient over time. So when we think about external resources, it's both people, but also the ability to access other sort of beings or other systems that help us to get our needs met. So our ability to regulate our own nervous system, and then our capacity to integrate our experience, which I think of as the ability to have enough of our prefrontal cortex, our thinking brain online, in the aftermath of an experience to make sense of it. And we'll talk in a little bit about the ways that the brain responds to stress and threat. But we know that the brain in a state of heightened distress and threat is less able to think, is less able to pay attention to ourselves and our own experience. And that disrupts our integrative capacity. So we're less able to make sense of and sort of place things in context such that we can move on from an experience and not carry the same sort of traumatic impact as we might otherwise. So thinking about these three different nervous system states, the goal is not to avoid any one of them, but to be able to sort of move between them. And so our developmental experiences shape the functioning and the balance. So the balance being if we're more dominant in our sympathetic state, where we're sort of hyperactivated, we're in more of that fight or flight state on a more regular basis. That dorsal vagal state, where we're in more of a shutdown, collapse, sort of unable to cope state, or if we're able to access more regularly that ventral vagal state where we can connect to ourselves and connect to other people. And so our goal is to be able to sort of move fluidly between these states in response to the environments and the situations that we're in, and then to sort of have the resources to move back into that ventral vagal state when necessary or when we're sort of out of the stressful situations. And so the goal is to not get stuck in one state or another. And the experiences that we have early on significantly shape our ability to do that successfully. So we could probably spend an entire day talking about the brain and the response to stress and threats and trauma. So we'll talk just briefly about a couple of specific things because they have some implications as we begin thinking about adverse childhood experiences. And so PFC stands for prefrontal cortex. This is our thinking brain, our higher level functioning, our ability to sort of sequence, plan, use language to keep track of time, to better differentiate between past, present, future. So this is an important part of our brain that takes up probably the greatest amount of acreage in our brain. So our brain, as humans, we have a significant portion of our brain devoted to these higher level functions. What we know is that in response to significant threats in either that dorsal vagal or that sympathetic states, our prefrontal cortexes largely go offline. There's less blood flow to them, there's less activity in them, so we become less able to access our language centers and put things into words. We become less able to process situations and put them in the context of our total history. We become less able to differentiate between whether something is a threat or not, which is an important thing in the aftermath of trauma that's oftentimes impaired for people, so that things that historically might have been neutral or more innocuous are now perceived as a threat. The hippocampus is the memory center of the brain. It's actively online as we're learning and making sense of our current experience, as well as when we're recalling memory. And we also know that in significant stress states, there are neurotransmitters that connect to the hippocampus and shut down its functioning as well. So we become less able to effectively access our memory system, as well as to make coherent memories of our current experience, which is a significant part of why traumatic experiences have this long lingering effect, is that they're not made into coherent memories in the same way as sort of calm, relaxed experiences are. The amygdala is the part of the brain that's responsible for threat reaction. So it comes online and tells us we need to respond to this. So it's sort of the alarm center of the brain. It's responsible for scanning faces and looking for sources of threat in our environment, and then activating our stress response system in response. And then part of what it connects to is the brainstem. And the brainstem is more of this lower level, primitive part of the brain that is part of that fight, flight, freeze response that comes online in response to stress or threat. And so we know that there are parts of the brain that become less active and less and receive less blood flow to them in response to stress and threat. And the challenge is that for people who are persistently in stressful states, is that these sort of less active parts of the brain actually have lower volume across the lifespan for like children who grow up in high adversity environments. Their prefrontal cortex has a smaller volume. Their hippocampus has a smaller volume. The connective tissue between the right and the left sides of the brain has has less sort of connective tissue. And so the brains of children who are significantly exposed to stress on an ongoing and recurring basis change in response to the absence of safety and regulating caregivers. And so this will come into play as we begin to think about why adverse childhood experiences have so much of an implication on our sort of long-term trajectory. So as we think about how our concept and our understanding of trauma and PTSD has evolved, particularly over the last century, I think we can see that there's been a big role that the military has played and military mental health has played within that. Certainly trauma didn't begin in the last century, but our beginning to have language to put to it really began to evolve in a more advanced and I think nuanced way over the past 125 years. You can see the evidence of trauma in a variety of different historical accounts and literature accounts throughout history. And so people have documented that people are impacted by the experiences that they go through. But the real language of putting trauma as the name to that really began to evolve over the early 20s of the 1900s and to now. So we've had sort of language to put to it, but I think some of the early acknowledgments realistically started with looking at men in combat situations, and more often that was looking at white men in early combat situations. And that became sort of the primary point of focus of our understanding of what has evolved to be known as PTSD in present day. But fortunately, our recognition that it's not just those people who are involved in those settings who are experiencing trauma has also shifted and evolved across time. So psychology really began developing as a field in the early 1900s. And prior to that, there was some recognition that people are impacted in the Civil War. Railway accidents were recognized as a source of sort of impacting experience, even though they didn't put the word trauma to it at that time. And even some of the early exploration of what hysteria is or was back in the late 1800s, early 1900s, most of the early explanations focused on trauma as being the source of or the driver of what was labeled as hysteria for typically young women at that time. In World War I, it began to sort of evolve where we began to sort of talk about shell shock, that we began to see that there was sort of this embodied nervous system disruption. They're struggling to put words to what exactly was going on there. This continued to sort of play out over World War II, where we kept sort of watching. The real emphasis typically was on how do we get these soldiers who seem to be impacted by what they're experiencing back in the fight. And then seeing that the people carried some impact of that long after they left. And so mental health began to sort of be inserted into the military over World War I, World War II, and into the Korean War. As we moved into the 1970s, there continued to be some exploration of what military personnel were experiencing in the combat setting. But fortunately, there also began to be a more clear recognition that it was not just combat experiences that were driving this sort of traumatic impact. And so by the time the DSM-3 was published in 1980, there began to be more of a recognition that there's multiple experiences that could contribute to post-traumatic stress. It took a while for that to really come online. And also in the 1990s, the first adverse childhood experiences study was completed in 1998. And so in the 80s and 90s, there began to be a bit of a shifted exploration of what post-traumatic stress and this label of trauma means. And it's only, I think, increased as we moved into the 2000s. We now have technology that allows us to scan the brain, look at nervous system states to better understand how the brain responds differently in different people to experience. And so that's helped give us better language to put to trauma and dissociation and some of these different ways of looking at how one experience can create a variety of effects for the people who go through it. The average childhood study, or childhood experiences study, was replicated nationwide throughout the 2000s, which is fortunate because the early study was predominantly whites in the HMO environment, and has now been expanded to include a much wider range of the population, and has given us a more nuanced understanding of how adverse childhood experiences are different across society. There also began to be a exploration of what has been termed epigenetics, which is the ways in which gene expression is changed by experience, and that can sort of be passed on from one generation to the next. So we began to have this scientific data that began to support what had been commonly, I think at times recognized, that trauma is passed down from one generation to the next. And epigenetics as a field really began to put language to that and help us to begin to see the ways in which that might be occurring in DNA and in gene expression. So then as we get to sort of present day, I think there's a growing push to be more trauma-informed in our care systems and our education systems. It's beginning to be more, at times it's a buzzword. Hopefully it becomes more than a buzzword and it becomes an actual shift in the ways in which things are done. But I think also there's been this shift as well from adverse childhood experiences to positive childhood experiences. So there's this opening to say it's not just the things that we're trying to help children avoid experiencing, but also the things that we want to foster them having experiences of. So that shifts our language to begin thinking more about community prevention, as well as thinking about the ways in which we provide treatment to people. And that's hopefully where this conference is heading, our organization and our engagement with our community partners. So PTSD, we're not going to spend a ton of time talking about PTSD itself, because I think PTSD is frequently recognized by professionals in the field as a limited concept. It doesn't fully capture the impact of trauma. And I think as we'll talk a little bit in the coming slides, we'll see a little bit why that is. But the classic definitions of PTSD is you're exposed to a traumatic event that's life-threatening or has some, that activates some fear that you're going to be bodily injured, or you're witnessing the injuries to others. It typically leaves people with intrusive symptoms, so flashbacks, nightmares, intrusive memories or thoughts. People begin to have more of a life, oftentimes a life centered on avoiding the things that feel unsafe to them. And there's significant disruptions to their ability to function in day-to-day life. And that's oftentimes driven by those nervous system states, those sort of more survival-driven nervous system states being more primary for people who have experienced trauma and are now experiencing post-traumatic stress. It has to last longer than a month after the event that somebody went through. And as we know from research and clinical practice, it can last for years beyond the initial experience. And sometimes people will go through an experience and not experience any sort of these primary symptoms immediately, and they'll sort of be more of a latent expression of post-traumatic stress. Well, sometime after, something will activate those memory systems and bring those symptoms back online. So SAMHSA provided, I think, a more nuanced description of trauma that goes beyond just the experiences that contribute to a post-traumatic stress diagnosis. So they say trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Another description that I really liked was that trauma can be thought of as what happens to a person where there is either too much too soon, too much too long, or not enough for too long. So it sort of broadens our range of experiences that could be sort of or that could result in a traumatic impact. So psychological trauma, as we think about it then, is it overwhelms the person's capacity and ability to respond effectively. So their resources are not enough to get through the experiences. Those fight or flight responses don't actually reduce the threat. They shut down and freeze or collapse, and it doesn't actually get the threat to go away. And so people are left with this unintegrated nervous system state, and frequently the residue on a memory level and a thought level of what they went through. And so we know that our capacity to respond to situations will change across time. So if I'm 3 years old watching my parents fight in a room versus if I'm 30 years old watching my parents fight in a room, I'm going to have a very different experience of that. And so the younger that we are when we're going through a variety of experiences, as we'll see in the coming slides, the more impactful those experiences might be, and the more overwhelming they might be to our resources and our ability to cope. So the original adverse childhood experiences study was completed in a healthcare system in California in 1998. As I said, the predominant population was an HMO system that they were surveying, and so it skewed about 75% white, more educated, more middle class in terms of the population that they were surveying. And yet what they found, well, that'll be the next slide. So what they found when they began to ask these questions, specifically centering on three categories, so abuse, three different forms of abuse, household challenges, including violence within the home, substance abuse within the home, mental illness within the home, separation or divorce amongst the primary parents, criminal behavior such that a parent was removed from the home, and then two different forms of neglect. And then this slightly expanded when they expanded the survey beyond this initial survey, and for what was called the behavioral risk factor surveillance system. So they actually do phone surveys where they call people and ask them questions about their lives. And so they expanded the definitions of sexual abuse and removed neglect initially. It's been returned since then. But what they found was that there was a high rate of people, and we'll see this in the coming slide, that reported having experienced these adverse childhood experiences. And part of what they were initially looking at is how does the presence of these experiences in childhood affect the utilization of medical services, the medical diagnoses that people experience, and the overall health and well-being for people. And it was very significant, as we'll see in the next couple of slides. So our current sort of iteration of adverse childhood experiences includes abuse, neglect, that was added back, and then those household challenges, as well as other forms of adversity, including bullying, community violence, natural disasters, refugee or wartime experiences, and witnessing or experiencing acts of terrorism. And then there's this other layer that we'll talk about in a few moments about adverse community experiences that is now being factored in more significantly as well. So the broad research that now shows, and this is over the last decade, specifically looking at a more representative population sample, is that 64% of people report experiencing at least one adverse childhood experience throughout their developmental years. That's up to the age of 17. And 17% are reporting 4 or more adverse childhood experiences during those first 17 years of life. And I'll acknowledge that with this slide, so the CDC, who's the primary sort of driver of the ongoing data collection, has a number of different presentation materials, which is great, so you don't have to be a graphics design whiz yourself. So some of the language on a couple of these graphics is not fully representative of descriptions of people or groups of people. So I'll just acknowledge that because that's the way they framed it in terms of their data collection. So there is some research that shows that some groups of people experience a significant increase in adverse childhood experiences. So people with a lower education, high school or less, people making less money, so poverty, and this is one of those things that we'll talk about with adverse community experiences, is that poverty is also a contributing factor to these sorts of experiences. People who are unemployed or unable to work, people in marginalized communities, both racially as well as with regards to orientation, sexuality and orientation. And so there's a continual improvement, I think, in our ability to sort of better capture how adverse childhood experiences are more broadly distributed across groups of people and across different SES or social economic status in our society. So the research is fairly troubling when we begin to think about the exposure to adverse childhood experiences and the long-term impact of those experiences, especially when we begin to think about what percentage of people are reporting having one or more adverse childhood experiences. And so a variety of health conditions, variety of mental health conditions, different health risk behaviors, so things like smoking, excessive alcohol use, sexual behaviors, as well as suicidal thoughts and attempts. There was some of the early research showed that 4 or more adverse childhood experiences increase the risk of suicide by 12 times, increase the risk of injecting street drugs 10 times, increase the risk of alcoholism or other addiction 7 times, and that if you had greater than 6 adverse childhood experiences, it took 20 years off of your expected lifespan. So it's significant. And the research continues to show that living in a prolonged survival state, so again, thinking about those nervous system states that we were talking about before, has a disruptive effect across organs, organ functioning, tissues within the body, and brain development. So as we talked about with the brain, we know that there are parts of the brain that don't develop fully or don't sort of develop and function as effectively if people are left in prolonged survival states. And what we know about epigenetic research and the transmission of trauma from one generation to the next is that this can then be passed on from one generation to the next and continue to contribute to the possibility of adverse childhood experiences in the next generation, where there might be things like poverty or greater difficulties with work. And so fortunately, our exploration of childhood adversity and the adversity that might be experienced within particular community environments is increasing in our understanding and adding further nuance. There's a slide in your folder that will show 3 types of ACEs, so that will include both adverse childhood experiences, adverse community environments, as well as climate experiences. So sort of just centering on this, thinking about the primary ACEs, so that's what's up there on the tree, but then thinking about the sort of the ground from which those adverse childhood experiences come out of. Things like poverty, racism, discrimination, the disruptions to community and community experiences, housing, community violence. And so these are sort of the what was the word I was going to use? I mean, these are sort of the foundation that sort of contributes to the perpetuation of adverse childhood experiences. And so both have to be addressed. So as our understanding has moved from just sort of post-traumatic stress as sort of being an individual experience that we need to focus treatment on, is that we need to now begin to think about both the community experiences that people are having and the environments. How do we change those states, change those sort of conditions to try to reduce the likelihood of adverse childhood experiences occurring and hopefully improve the trajectory for people across time. So this was a conceptualization coming out of the early ACE research. So when we begin to think about the presence of generational or historical trauma, the ways in which that affects people's nervous systems, just even at a genetic or genetic expression level. The experience of social conditions, as we were talking about a moment ago with those adverse community environments, that then increase the likelihood of adverse childhood experiences. We know that the presence of adverse childhood experiences and the states, the nervous system states, and the brain disruption that occurs for children begins to make it less likely that they'll perform well in school, that they'll be able to effectively process experiences and make good decisions. There's a part of the brain in that prefrontal cortex that's responsible for inhibition. So when we feel an impulse, whether or not we act on it. And we know that that part of the brain becomes compromised when people are in a stress state. So part of the design to survive is to not think about surviving, but just to do. So that fight or flight is not necessarily a thought out sequence. And so we become more impulsive. We have a more difficult time sequencing our behavior and thinking, if I do this, this is what's going to happen. So that has a disruptive effect on relationships, people's ability to perform in school, and contributes to the likelihood that they'll engage in health risk behaviors. So they'll be more likely to do things that are impulsive or things that just regulate their nervous system, which then contributes to greater risk of health compromise and different sorts of diseases or health conditions that will contribute to ultimately an early death. So this is sort of the thing that we're now as a society and as a sort of a broader sort of body of researchers and sort of treatment providers and community agents and community activists are really looking to sort of influence each of these different levels. Unfortunately, research shows that just as sort of adverse childhood experiences can be disruptive to our ability to sort of thrive across the lifespan, the presence of positive childhood experiences can be a countermeasure to that. And positive relationships can help to create a buffer against the sort of that trajectory, that previous pyramid. So this is a pyramid that sort of provides, in some ways, a different solution. So we begin to move to becoming more trauma aware, recognizing the impact of trauma, both historical trauma, collective trauma, as well as our personal experiences of traumatic experiences. Begin to recognize what experiences we can begin to try to foster in our communities, what sort of system conditions or societal conditions we need to work to reduce the likelihood and the perpetuation of, to try to improve both our systems of care, but also the conditions that exist around those systems of care, and create sort of a greater capacity for people to be in environments that feel safe, and for them to get the support that they need, which ultimately puts people on this trajectory to show up across the various systems and settings of their lives to be more successful, and to sort of to shift our sort of ongoing societal trajectory to become one that's more just, equitable, and safe for everybody. So real briefly, we'll touch on, like I said, one of the knowledge sessions will touch more specifically on the different elements of a trauma-informed care approach. But sort of central tenets of a trauma-informed care approach is realizing the prevalence of trauma in its various forms, right? So it's insufficient for us just to look at post-traumatic stress as the primary understanding of trauma. We have to look at this broadened definition, which includes adverse childhood experiences, as well as those adverse community environments. Recognizing how all of us have nervous systems, all of us are exposed to a variety of experiences, including the people who are in a workforce, whether it's teachers in a school, providers, nurses in a healthcare setting, community sort of social support. Recognize that everybody is affected by life experiences, and we all need the tools and resources to maintain resilience across time. And this has to change the way that we do things. So we can't just maintain the status quo, because we recognize, as Jesse shared, that our systems have been broken for long periods of time, right? And we have to begin to do these things differently to create systems that are fostering safety and the capacity for connection and healing for everybody. And then finally, avoiding re-traumatization and the replication of traumatic dynamics and imbalances of power. Right? So thinking about adverse childhood experiences, that could be sort of avoiding re-traumatization that we think about in terms of childhood environments. But then when we broaden that out to think about, we also have to avoid those power imbalances that result from societal forms of oppression, racism, bigotry, discrimination. And so those things have to be challenged within our systems as well. So I also think trust and safety results from predictability and consistency across time. And so these things take time for us both to implement, but also to demonstrate that we're doing things differently than the status quo has looked like for a long time. So we have to begin to acknowledge both the reality of trauma in all of its forms and its impact, work to change the conditions that perpetuate trauma and adversity, cultivate safe experiences, environments, and relationships, again, sort of across all these different areas, and then restore the possibility of corrective healing experiences. And so the systems that we exist in and interact with will have a dramatic impact on our nervous system states. And so if we begin to recognize that, it creates a greater capacity for our systems to support a greater accessing of that ventral vagal social engagement system, which allows all of us to sort of live, work, and be at our best. So that's the end of my time with you. Thank you for your time this morning. Hopefully provided some inroads to understanding trauma in sort of its diagnostic form, but also in this broader way that we need to understand and think about trauma to really sort of shift our systems and our experiences across society. So, thanks.
Thank you, Dr. Van Wyk, for helping us understand the legacy of trauma and the importance of trauma-informed care approaches. At this time, we'll take a brief break and regroup at 10:15 in this room. Thank you.